So here we are, ASMBS 2025, Washington, D.C., this time with Dr. Eric Smith. And I have to say, Dr. Smith, I've heard your name now for probably a better part of a decade. Of course, you're from the Kentucky area. I'm an Ohio guy.
Yeah.
And it's been associated with master surgery, being a great bariatric surgeon and just a great robotic surgeon. That's what I always hear about. So today I finally get a chance to meet you and pick your brain. I want to start with, here we are at ASMBS. Where is it that you think the bariatric world is right now, and what are the big issues that it's dealing with that it has to face in the next, let's say, year to 2 years moving forward?
Well, that's a good question, and it's probably the best time to answer that right now, because I think the bariatric world, if we want to call it that, is as ever-changing as it's ever been in my career. I've been doing this 19 years now, and I think we have to be really careful, because when we say the bariatric world, we have to remember, even though we're a bariatric surgeon, that bariatrics covers the treatment of obesity. And so it probably makes the most sense to be talking about this, because we now have so many options on how we can attack the disease of obesity. So, things are changing on us as surgeons, how we not only have to look at patients, how we have to treat patients, how we have to embrace patients, but what do we have to offer them when they walk in our office?
Yeah, and I'm assuming you're obviously talking about the GLP-1s and their effect. And you're right, everybody here is talking about it. What is your perspective on GLP-1s?
So I think GLP-1s are just another set of tools in our toolbox so that we can go after a disease that, let's be honest, we've not been super impactful in treating. Now, let me back up and say the ones that we're treating, the people that we're treating, we have great data that shows how impactful that can be for those patients. But why is it for the last 20 years that 1% of the population who would qualify for bariatric surgery is actually having it? Now, I think there's a ton of barriers. Maybe we don't have enough time today to talk about all that. But no matter what, even if we're doing good surgery, we're not getting the point across. And I think the biggest blessing that came from the GLP-1s is it had the money of Big Pharma behind it to finally raise awareness that obesity is a chronic disease that we're treating. We really hadn't been successful as a surgical society in getting that point across. And so if anything, we can thank them. We can thank them for pulling in the Oprah Winfrey's of the world, the national TV events of the world, although I'm not a big fan of necessarily mass marketing, so to speak, unless it's done the right way. It's raised awareness, and now people have started to accept this is truly a disease, and now they can take a step back and say, so what's my best treatment options, and what's the most efficacious? So I think it definitely has a role. Do I think it's being overutilized? Absolutely. Do I think it's a little scary when we take a medicine for a disease like obesity and just say, if you can write a script, you should give it? Because we know as bariatric surgery programs, there's a whole gamut of resources we have to have for mental health support, dietary support, education, long-term follow-up. And a lot of the GLP business is turned into transactional. So I think we need to learn from that and take a step back. And we as surgeons need to be aware that we're the best suited people to be giving these medications because we have all those resources in place.
Yeah, I mean, bariatrics, my entire career, about the same as yours, I think we're about the same age. It's been a whole body approach, a whole person approach to a system. And I think I agree with you that the bariatric surgeon probably should be the one managing the patient in the short and long term, and really keep an eye on what all the possible opportunities are that are out there for that patient.
Right.
It's been brought up multiple times now. It's more of almost a cancer approach, chemotherapy versus surgery versus
Absolutely.
It's the same kind of idea. In the modern setting, where do you see the GLPs fitting?
So I see the GLPs fitting in that lower BMI category. I think it's the entry point when somebody finally gets to the point that says, you know what? I realize that this is a disease. I realize that I'm losing the battle just trying to, quote, change things in my diet. They've been given a lot of bad information by, unfortunately, many times physicians of you just need to eat right and move more, which is crazy. So it's really discouraging for them. And I think this is maybe easier for them to take that first step. So if we take a step back and look over the last 2 years, we see the number of people that are being operated on, but we have to consider the number of people that are taking medications. And many of those people may find that those meds aren't enough. But at least it has had them open their eyes to, all right, this was partially effective, and now I'm more comfortable. We're seeing more and more patients now who come in for their surgery appointment who have tried the medications maybe 18 months ago, just couldn't tolerate them, couldn't afford them, didn't like how it made them feel, didn't realize or realized it didn't give them enough weight loss, and then they've transitioned over. So I think it's that lower BMI patient, that patient that for whatever reason is maybe not ready to embrace surgery yet. And I think it goes back to the fact of us as surgeons, we have to stop looking at patients of, you come to me when you're ready for surgery. And that's how we've always dealt with it, right? We didn't want to be bothered with somebody unless they were ready to have surgery. We have to now meet the patients where they're at. And that means, are you willing to talk about treating your obesity? And if it's a yes, come on. And we have to be willing to nurture that patient for 3 months, 6 months, even 12 months. If they say, I'm not ready for surgery yet, but I'm ready to seek out help. And we can provide that help for them. And whether it turns into surgery, great. If medicine works for them, that's phenomenal too. Our job is just to make them healthier.
No, I think it's especially, you're in Kentucky, I'm in Ohio, and there's that stigma that I always say, that blue collar belief. It's like, if I just work harder, if I just do a little bit more, if I eat the right thing, I'm gonna solve this problem. And then it doesn't work, and then they fail, and it's that failure after failure, the attempt after attempt. I mean, it's gotten to the point where when I was younger, I had that belief system, and I thought that if you could just get these people to eat the right or to do it, but it doesn't. We know that's not true. Science has come out and they said that is just not working. It's not going to fix this problem. What do you think is behind all this, and how do we change the stigma that has existed for at least my entire life, and I'm sure it continues to this day?
Well, we talk about, and you and I've talked about this earlier, but we talk about obesity is multifactorial. There's so many things involved. It's genetic, without a question. It's the socioeconomic. I mean, we can look in parts of the world and parts of the country in the United States and see the incidences are very different based on socioeconomic status, what resources they have in place. We could go on and on. All those things play a role. And so we have to address those as well. You were talking about working harder, but some people have to work even harder than somebody else because they are genetically predispositioned to maybe not respond to what one person is doing versus the other. In my opinion, the root of the problem is our food system, without question. And no one's really addressed it. We know that calories in, calories out pretty much is going to dictate if someone gains weight or loses weight. I think we have to be careful with that because we really shouldn't be trying to help people lose weight. We should be helping people lose body fat and maintain muscle mass. But the mass marketing of the food system has been gauged towards our patients that struggle. If you think about it, all the front of label packaging is, or front of package labeling is all focused on low calorie, low fat, no carb. But there's so many chemicals in our food that, yeah, that person may not gain weight from that low calorie food, but it causes them to eat so many more foods throughout the rest of the day that they are exceeding it. And our food system, without question, we've proved it, is designed to make people addicted to eat more of it. They're selling a commodity. The food systems were all bought by the tobacco industry years ago. They were sold, but their scientists were left in place in engineering these foods. And until we change that, I think we're going to be spinning our wheels, and we have to be aware of that.
Oh, 100%. And it's hard to get somebody to say what you just said, but I stood back about probably 18 months ago, and I looked at our medical system. I realized we're not in any way challenging the cause of this.
No.
And yet we're all facing it. I mean, you're as a bariatric surgeon, this is your world, but every surgeon, every doctor, this is in front of us every day. And you're looking at 70% of the population now is overweight or obese. I heard numbers of 400% increases in BMIs over 60. Like, I thought they were at least starting to plateau here. No, it's just getting worse.
Right.
And so how are we supposed to fight a battle if whatever's causing it just continues to get stronger and stronger? Like, we're not making any gains.
I did an article for Newsweek when the conversation came up about the government providing access to the GLP-1 medications. And I probably made a few people mad because I said, look, I'm all for everybody having access to this. But if all we do is give them access to the medications and we don't change our food system, it would literally be like back in the 80s and 90s, we went in and said, we're not going to blow up big tobacco, but we're going to continue to invest in more and more chemotherapy drugs to treat lung cancer. So we're not going to change how people are getting lung cancer, but we're going to throw more money and meds, and the pharmaceutical companies are just going to rake it in. We have to get to the root of the problem. You're putting a Band-Aid on a malignancy. And so if we can change the food system and we can give access to people of these drugs and surgery. State of Mississippi is #1 obese state in the country, and they don't have, their state medical system doesn't provide coverage for bariatric surgery right now. So that's great and wonderful, but if we don't get to the root of the problem, all we're doing is perpetuating a problem that Big Pharma is just waiting like, yes, we've got a chronic disease medication. This is awesome. And let's just keep doling it out. We have contract with the government for it. So it's not always a popular opinion, but it's factual.
Well,
and
I mean, I always get an example, MSG. And I'm not here to attack MSG, but you're talking about a chemical that's designed to make you eat more food. That's the point of it. It makes the flavor, and it makes you eat more. So we have an obese society.
Only purpose it serves.
That's the only purpose it serves. And we don't do anything. Nobody questions the fact that we put it on almost everything to make us eat more when we already have a problem with eating too much.
You know, you may have to edit this out, but if we were to ask 100 people in this lobby, what's the number one fast food business that you can't get enough of, that you love? Which one has the longest drive-through? It's Chick-fil-A.
Yeah.
What fast food has the highest level of MSG of all the fast foods out there? Chick-fil-A. That's not done by accident. They didn't put it in there like, well, let's see what happens with this.
Yeah.
There's intention behind it. And again, I don't think we should take away people's freedom to choose what they eat, but what we should do is be very transparent about what's in it. Our SNAP programs, over 60% of the foods that are on the SNAP list are ultra-processed foods. Coca-Cola sells 15 to 20% sometimes, depending on the year, of their sales to SNAP programs. And we're supposed to be providing nutritious foods to the population who can't financially afford nutritious foods, and we're providing chemicals. There's not a single nutritional product in a Coke or a Diet Coke for that matter. Why are we're duping them, you know? And it's not taking that freedom away. It's saying we owe it to you to provide nutrition, not chemically engineered edible products.
And I think this is where it gets difficult. And I agree with you 100% on everything you've said. They come back and they're gonna tell everybody they're stopping you from making your own decisions. They're stopping you from having your choice. You want this and you have the right to it. It's like, yeah, agree. Like, I'm not trying to say you don't, but they're also not telling you that it provides no nutritional value.
Right.
And that they're adding these things to it, and they're making sure you don't understand what they're putting in it. And you go back to what the companies figured out. I mean, like the sweet spot, like they figured out how much sugar to put in anything to make you addicted to it, because sugar's as addictive as any drug.
Yeah.
And they figured out that's why, some companies have to announce it in Europe that it's a pastry when it's a piece of bread, because there's so much sugar in it.
Right.
In the United States. And that is it's just knowledge. It's just, this actually matters.
Yes, we didn't take away anybody's right to buy a pack of cigarettes. We've never taken that away. You can still go to the store and you can buy that. But they were required by law to be very transparent. And if you look over the course of the last 20 years, a lot less people are consuming that because they made the choice that maybe this isn't good for me.
Yeah. I mean, even when the calorie counts came out, and I was like, do we really need this? Do we need to be force everybody to do these calorie counts? But I'll tell you, I mean, I've looked at a menu and went, is it worth 1,500 calories for that?
Absolutely.
And I made a different decision. So do I think that has some influence? And it's going to be nibbling away at what's influencing this, what's influencing this. And that's the whole multifactorial part we talked about. Like, we can't just target one thing, but I definitely feel like we have skipped out on the foundational cause of all of it.
Well, we have, as has been well put by many people, we have a health system with no interest in food, and we have a food system with no interest in health.
That's the quote
and
right
there
there.
Are two ships passing in the night, and they're not even remotely close right now. And I think the one last thing that I'll say that concerns me about the GLP-1s is the pharmaceutical companies have just pounded a term called food noise to the public, that it quiets the food noise. There is no such thing as food noise. There's chemical noise. People don't get food noise from eating whole foods, eggs, chicken, beef, vegetables, fruits. Forget the macros. Just eat whole foods. But these foods are engineered to cause you to crave them. And so we can't continue to give someone a medication to quiet the noise when the noise is created with a drug. It would be like saying, you know what, don't do cocaine 5 times a week, just do it on Monday, and I'll give you a drug so you don't do it any more than that and harm yourself. We have to be honest with these patients and say, if you remove this from your diet, your noise will quiet down. So I really warn people, don't use this drug just for food noise, because you can fix that. It takes time, but you can. But it absolutely can help with the weight loss.
This episode of The Cutting Edge will return after this.
pharmaceutical company is treating a problem created by the food industry, and we sit in the middle going,
Right.
like, but then they're all worried about costs. It's like, well, go after the ones that are creating the problem.
Yeah,
Like
absolutely.
because the patients, I mean, fundamentally going back to the stigma, I don't, you're not going to blame the soldier who gets thrown into a trench that he gets PTSD or she gets PTSD, because they were put into an environment that's going to create this, and we accept that now.
Right.
But we've put humans in our population into an environment that creates obesity. It obviously does. 70% of our population has some problem with this, and yet we're going, it's their fault.
They're bouncing back around like a ping pong ball. And I'll tell you what we're seeing now. And because of my involvement with social media and things like that, I can tell you in private conversations, there are influencers that have millions of followers because of their weight loss journey. And they have changed so many people's lives with sharing their story and telling their story. But they're sitting down with me because where are they making their money? From low calorie foods who are saying, promote this syrup, promote this thing that you put in your coffee, whatever. I'm not going to try not to pick on specific companies. And now they're saying, I can't quit craving things and I'm starting to regain my weight. Is my surgery failing? I'm like, no, you're exposing yourself to so many chemicals. And now they're gravitating towards taking a drug to quiet the noise before they've regained weight. But they're at this crossroads because these people have helped me create a business model, and their intentions were good, because they're focused solely on this low calorie food that is not nutritionally dense. And it's exacerbating the problem. But again, that goes along with creating a medicine for a chronic disease, and your goal is to keep it as chronic as possible to where it's dependent upon that. We have to be really careful with that right now, and we're seeing it.
Yeah, and then on the back end, as you talked about earlier, only 1% is getting any sort of access to the treatment that they probably need of the total population that really should have access to
Right.
it. And you've been on the cutting edge in the front end of the robotic transition in bariatrics and treating that 1%. Where do you see that in terms of, is the robotics the way to go? Is that the future from a surgery standpoint? And why are we seeing that as the future?
Well, I think without question, I think it's the future. And I think if you look at the trend over even just the last 3 to 4 years, when I started doing my bariatric surgeries robotically, there was only about 1% of us in the United States doing it that way. Now we've just surpassed over half of the surgeries in the United States are done robotically for bariatric surgery. And you look at some states, 80%, 90%. We have the most challenging patient population from a body habitus standpoint out there. First and foremost, it gives us access to be able to normalize that. It allows us to kind of standardize those procedures, remove that variation. The old adage of robotic surgery is good surgeons don't need a robot. I can dig a ditch with a shovel. I can bring in a backhoe and do it too. I'm probably going to do the one with the backhoe much more precise, much more efficient, and I can get a lot more work done too. My outcomes are going to be better, I promise you. If it makes me feel better about myself when I lay down at night, who cares? What I can do is it's allowed me to do what God has blessed me to do, and that's treat patients. And so I'm able to do 7, 8, 9 cases, not with another surgeon flipping rooms with me, but me by myself on a robotic platform. I can treat more people. I can help more people. That's what we're here for. But I think the way we're moving now with DV5, the technology, case insights, we are actually going to be able to sit down and stop talking about, I think I'm really good, and we're going to find out. And it's not to say we're not good. It's how can we get better? The best of the best. Tiger Woods fired his swing coach twice during his career, and he was killing everybody because he was obsessed with trying to perfect his art. And I think that's what we should be doing as well. And Case Insights is going to allow us to do that.
When you say Case Insights, I don't have the DV5, so we're operating on the other platform. What does that mean? What is that offering you?
So now when I operate, I can get content from that surgery. Not only do I see the video. In the past, we as surgeons, we always, I'm faster. I must be good, right? But that was really never connected with outcomes. Eventually, as we start to marry this information with actual outcomes, the hospital data, the surgical data, I can not only say, well, this is what good looks like, but I can say, how do I get to where good looks like, whether I'm helping a young surgeon or even myself. So with Case Insights, I can look at things like how many times I clutched my camera, how many times I clutched my instruments, which is really just saying I'm working tight. I'm working with my wrist instead of my forearms like we did laparoscopically. Now, how much force am I placing on tissue? When I'm placing force on tissue, is it in those critical aspects? Can I reduce that? Can I improve upon that? Can I improve my efficiency? And we are going to, in the next 4 or 5 years, I firmly believe, we're going to have the data where I can literally take, I call it Mia, since we have names like Siri, and say, Mia, show me my best room-wide gastric bypass with the most efficient gastrojejunostomy paired with my best outcomes, most cost-effective, and we're going to find that. And it's going to spit it out to us. And we're going to look at that, and I'm going to say, this is what good looks like, not just look at me, but our job as surgeons and teaching surgeons isn't just to stand up there and say, look how good I am. It's how can I help you get there? Because I'm just a regular guy. If I can do it, you can too. But here's the tools of how you get there. And we're going to be training residents and fellows that way as well.
I do think that, and I agree with you 100%. I think that the more data we have and the better we can iterate ourselves, the quicker you will be a better surgeon, and the more that we can train other surgeons to be better surgeons.
Right.
I think the problem or the fear would come to the aspect of insurance companies getting a hold of this data, because if they understand it, then they're going to say, well, I want everybody to go to Eric because he's the best in this area, and why take the risk of somebody else doing it? But then they're never going to get the experience. They're never going to have the process, opportunity to iterate their processes and to improve themselves. And so how do we prevent that Pareto distribution from developing where 20% of the population of surgeons is doing all the work?
I think that's a good concern that we have to raise, to be unbiased when we look at it. But I look at the answer to that as being, that's really already happening if the hospital system has the resources financially to pay enough people to crunch the numbers to make it look right and clean up the data. Now we can actually look and see what we do in the operating room with our hands. And competition's a great thing. I mean, let's be honest. Intuitive has competition on the market. Intuitive has never shied from that. It's going to make them even better. Because competition, if you and I are in the same market, we're going to hold each other accountable. We can be peers, but we can be taking care of the same people, and we just want to do the best job. And if we rest on our laurels, we'll get crushed, and we should, because patients will go elsewhere. So it really isn't anything new. We're already doing that. We as surgeons, I think we should be transparent, not to be punitive, but to say, you know what? I'm not as good as I thought in that one area, but now I have resources to get there. And if everybody's trying to be the best, the only person that benefits is the patient, and that's what we're here for. And if we're not, then we're probably in this for the wrong reasons.
And I think you're right. I think if you look at it, and now we have real data, because up until now, it's somewhat subjective.
Right.
Like there's a lot of politics involved, internal politics in your hospital, regional politics.
Yes.
All of that plays out, and it plays out in a way that is not necessarily in the best interest of the patient. Sometimes in the best interest of the hospital.
Right.
Rarely in the best interest of the surgeon.
As a surgeon, right.
And so I do think that finding the correct data, and that's the other question, is what's the correct data? Like, what should we be evaluating? And making sure that it's used in a way that's for outcomes, for patients, and for surgeons, I do think is going to be critical. And now at least we have it.
Yeah, when the early research on Case Insights was done, they looked at prostatectomy as the easy procedure because a ton of them had been done robotically. And when they pulled all that data, there was over 2,000 techniques of how robotic prostatectomy was being performed. Now, I think we're not urologists, but I think we know there's not 2,000 equal best techniques of how to do a prostatectomy. Now, I don't know what that number is. Maybe it's 100, maybe it's 200, maybe it's 250. But what if we can pare that down and start to find out maybe there's a better way? I think we as surgeons, sometimes we let our pride get in the way because we're like, what if I say your way is better than mine? That doesn't make me less of a surgeon. It makes me a better surgeon to want to say, you know what? Kudos to you. Let me find out how I can do that, because we're still going to have patients that we all can treat. We just said 1% are having surgery. There's plenty of people out there that we can help.
We say on Surgeon on our platform, I mean, people will put up a video and you're like, crap, that's a pretty slick little method they just did there. I'm going to add that in and act like I thought about it and just tell my staff that I figured that out.
Yeah.
But the reality is, that's the whole point, is you want to get these ideas out there. So, because I always tell people, if they think that surgeons talk, even if I talk to you, I'm not in your operating room. Like, I'm in my world. I don't know what's happening in the room next to me, let alone what's happening down the street or across the state. And yet it's this belief system that even if we talk, it doesn't mean that what you're telling me is what's actually happening in that OR. And how do we really start to compare what everybody's doing and come up with a true solution to some of these problems that we've been facing for decades in some cases?
Absolutely. And along with Case Insights, some of the other things that we can do with DV5 is a telepresence that's totally different than we've ever had. You know, we have we have one of the new cameras in the operating room that you on the other side can control. So you can drive it anywhere in the room, into the field, to see the nuances of clutching an arm or burping a trocar to create more space if we're struggling. But then they can drive that camera over to my hands and watching on the screen. Because I think a lot of times we miss, what is our hands actually doing? We see what's on the screen, but it's about clutching and positioning and all the nuances. And we have surgeons every week, multiple times a week, who are either in person, but even remotely, who maybe can't travel. But where we're getting now is we're going to be able to, I call it phone a friend or phone a surgeon, of say, hey, I don't need you to proctor me on the next 25 SATA, you proctor me on the first 3. But man, if I could just have you there for that duodenal dissection or for this part of the anastomosis, how do we work together? I think we can break down these barriers and just say, how do we make each other better? There's plenty of patients to go around. And I think the surgeons who are resistant to want to collaborate with their peers to get better, they're going to eliminate themselves. And no offense, but maybe that's not a bad thing, because it sounds like that there's a lot of selfish intent if that's the way that they think about medicine.
Yeah, I mean, if you have the patient in mind, and that's the goal, is to optimize the outcomes for the patients you're taking care of, for your community, then you should be looking for insight from as many people as possible to make sure you're doing the right thing. And if you're not willing to hear what other people have to say or see what other people are doing and really take a true evaluation of that, how honest are you being with yourself or your patients?
Absolutely. I've always said the day I think I've got it all figured out is the day I need to retire.
And we've all met those people.
Yeah, absolutely.
Yeah,
absolutely.
And I think that, that's one thing in our field we joke about. I always, the world of a surgeon ends about the length of their arm. Like, this is it. But I don't think that that's 100% true. Being on Surgeon and everything, like, there's a lot of sharing. There's a lot of people that really want to learn from others out there. And I think that joint effort is becoming a more commonplace aspect of surgery in the modern world. So you're right. I hopefully,
well, I think kudos to you guys, and as well as Intuitive. I feel like as my robotic journey has grown, my world of surgical peers has grown so much, and it's so welcoming. I've learned so much from my peers. Hopefully I pass a few things on to them as well. And you guys have a platform where people can at least feel comfortable from the comfort of their own home to get on and hear a surgeon talk about a procedure, watch a technique. I'll get messages behind, closed doors or sent to me, man, I still use that little trick you did with this. That makes me feel really good. Not for me to go say, hey, I'm the expert at this, but I helped somebody. And we're all in the business of helping people. I had somebody from Intuitive one time say, you're constantly on the move doing all these different things. And I'm like, I think it's just the nature of why I got into medicine. We just want to help people. And it doesn't always have to be a patient. It can be somebody else who's helping a patient as well.
No, absolutely. Absolutely. So I just want to end with, in the world of surgery, there's always the stuff we read in the textbooks, and then there's the pearls of wisdom, the things that you only learn from experience. What do you think that is that you would want to tell either general surgery population or a trainee or somebody coming on?
Oh, wow. That's a loaded question. I think the best lesson that you can learn, or best lessons you can learn, the best teacher that you can have in your career is your patients. Your patients will teach you so much. They'll teach you stuff in the operating room of how their anatomy responds to a technique that you use. They'll teach you so much about listening to them. I think as a bariatric surgeon, our patients teach us so much about what their trials and tribulations are. We can do the most elegant surgery in the world, but if they get out 6 months from now and they struggle, and we just say, well, my surgery's healed, I'm done, we've not really helped them. They teach us about what other resources we need to have. I look at ASMBS versus when I started. I look at the booths. I look at the resources. We now have so many programs that are resources for patients, for mental health support, for nutritional support groups, places they can go to kind of develop a community. And I think it's so vital for their success. So I was taught that at an early age in my training, that our patients would teach us more than anybody else. And I firmly believe that.
No, I appreciate that. That is true wisdom right there. So thank you for your time.
Yeah.
And once again, welcome to the Cutting Edge.
Yeah.
Enjoy the rest
Thanks
of the
for
time
having
at
me.
ASMBS.
Okay.
Thank you.
Yeah.